So let's talk a little bit about the concept of mobility or movement. There are a few different things we'll discuss here, um, including a couple of different maybe disease processes. We can call it that, and like trauma or injuries that can occur in patients that can ultimately affect their ability to move around, and that can affect a lot of different other systems, whether that be like mental, emotional, feelings of being able to be independent, or tissue integrity concerns that we might have related to mobility, injuries secondary to mobility concerns, and things like that. We're going to start with a discussion about osteoporosis. This is something that can occur in some individuals that leads to a decrease in the bone mineral density of patients' bones. If you look at the side by side comparisons of bones here, what we're seeing is that the osteoporotic bone kind of has a lot of spaces really in between all of that structure within the bone, which makes that bone weaker and more susceptible or prone to fractures. And so when we are taking care of a patient who has osteoporosis, or maybe they're kind of starting to show um, some signs that are maybe not quite osteoporosis, but they have weak bones, just not at that level of osteoporosis. We have that osteopenia. Then we can implement a variety of different interventions to help the patient maintain um, the bone strength that they have, or maybe increase bone mineral density, through activities, and to prevent injury from occurring. You can see here in this kind of skeletal image of a person how over time with osteoporosis, we can see some pretty significant changes in the curvature of that spine. We can see how, as this person has progressed in age, how much height they have lost because of changes within the vertebra, where they're probably experiencing maybe multiple compression fractures. It's kind of shortened those spinal bones, those vertebral bones, and is causing some pretty significant changes in not just the bony structures, but also how that curvature of the spine can affect multiple different other systems here. The thing that I noticed kind of off the bat is really how the head is sort of pitched forward, making it maybe hard to maintain good balance, maybe some discomfort concerns going on there with that curvature of the spine. That curvature of that upper spine there, we call that kyphosis. But also I can see that there's kind of like almost a shortening or compression of the thoracic area, maybe compromising um, ventilation, or somebody's ability to take nice deep breaths and inhalations. Maybe it's pushing down on the diaphragm and kind of compressing that, again making it difficult to take nice good adequate breaths. And then also I can see that we might be seeing some compression of structures within the abdominal cavity, maybe leading to issues like constipation or digestive issues. So while we think of osteoporosis as a bony concern, it definitely can have an impact on other body systems as well, because of those structural changes that we see in the skeleton. When we talk about osteoporosis, we often term this as what's called a silent disease. We don't really see outward clinical manifestations um, of osteoporosis, especially early on, until a patient has some kind of a fall or injury that results in a fracture of a bone. And so, for that reason, the best approach really for osteoporosis is identifying it early. And we do that by recognizing those individuals who maybe are at risk for the development of osteoporosis. So, people who are older have an increased risk. Certain types of races, like Caucasians and Asians, they too have an increased risk. Um, let's see what else. Women, especially postmenopausal women, we can see an increased risk there. There is um, a link between estrogen and strong bones. So when a woman is postmenopausal, the amount of estrogen that they have available is not the same. And so that increases their risk for osteoporosis there as well. Those things that we're talking about, those age, that gender, their race, those are things that we can't really change, those non-modifiable risk factors, but they can help us identify perhaps who we need to be screening for osteoporosis. Now, there are some lifestyle factors that we can take into consideration as well. Um, that would be maybe things like smoking, excessive alcohol intake, excessive caffeine intake, a sedentary lifestyle, poor intake of calcium and or vitamin D, excessive intake of carbonated beverages. So these types of things are really good, not only in helping us to identify maybe who we need to screen, but also helping us to determine where our interventions can be implemented um, for our patients as we're trying to help preserve bone um, mineral density or strengthen bone mineral density or something like that. Secondary risk factors include other types of maybe like disease states, things of that nature, or medications. Some types of medications like steroids. Um, I think a proton pump inhibitor called Protonix has been linked with osteoporosis. Certain types of anti-seizure medications have been linked with increased incidence of osteoporosis. Some absorption inflammatory diseases like rheumatoid arthritis or irritable bowel syndrome, Cushing's disease. If a patient has one of these things, is taking some of these medications, again, these are risk factors that need to heighten our awareness of who perhaps it is that we need to be screening. You can see in this picture that it's the same person, but you can see how the structural changes of the skeleton have produced some pretty significant changes in the stature of the patient. You can see what's called a dowager's hump. That's that kyphosis of the dorsal spine. Patients can lose as much as 2 to 3 inches of their height. They can also have things like back pain. Their pain might increase with activity. There's going to be some restricted movement or range of motion, especially in those regions. So a lot of times these patients have a fear of falling. Perhaps they've fallen before. That center of gravity is kind of pitched forward. And so maybe they've fallen before, or they feel unsteady. And so they have this fear of falling that might impact their desire to be mobile overall, or maybe they've had previous fractures before that they've had to work with. Additionally, kind of like I was talking about when we looked at that skeletal image that projected over time, other things the patient might experience, not really directly related to the bone mineral density, but simply because of the structural changes that have occurred. Might be things like constipation, feeling like they have abdominal distension, maybe some gastric reflux. All of this because of that decrease in movement and that spinal deformity. Respiratory complications, body image disturbances, clothing that won't fit, just a different you know, you look at yourself in the mirror and you look very different. Uh, Again, the best thing we can really do is to build strong bones as a young person through activities such as weight bearing exercises. So, if we can start to implement interventions in our young patients, our young individuals who are going to maybe be at risk in the future, young women, that kind of thing, and encouraging them to do those weight bearing exercises like weightlifting or good physical activity, walking, running early on. This can help to build up strong bones so that when they get to advanced age, they're going to have a better chance to have the amount of bone mineral density that they need. So there are some diagnostic tests that we do. We can look at just like like a generic old X-ray, but that's only going to show the loss of bone mineral density after a large amount of that density is lost. So if we really want to measure someone's bone mineral density, we do this through something called a DEXA scan. This is really the gold standard. We use it for screening. That's a dual energy X-ray absorptiometry. I think I'm saying that correctly. And this highlights the areas that might be at risk for fracture in the future. Um, the results that we get from a T score from this DEXA scan is something that's called a T score. And when that T score is low at a particular level, then the patient might be told that they have osteoporosis. It can also give us an idea if they're kind of moving towards that general direction. Maybe their T score is low, but not low enough to be osteoporosis, and perhaps they have what we would call osteopenia. Again, a good time to implement interventions to prevent further loss of that bone mineral density. There are some other radiological exams that we can do, like a quantitative CT scan, and this measures bone density. But it's not really for screening purposes, it's more for diagnostic management. It is predictive of spine or hip fractures, but it's more radiation exposure than what the DEXA scan has. MRIs, I guess those really aren't standard. They're looking more for perfusion, and they can kind of see like the bone marrow content and stuff like that inside of the bones. A FRAX assessment is really just a risk assessment screening tool that we look at various different clinical factors to predict a 10-year risk uh, for the development of fractures. So it's kind of similar, maybe in terms of a screening tool, is what we might think of the Braden scale as a screening tool. And it's not an X-ray test or anything of that nature. We might look at a couple of different labs. There really is no lab that's going to tell us that a patient has osteopenia or osteoporosis. But if we do find that perhaps a patient's calcium level or vitamin D levels are low, that could be something that we find useful in treatment of our patients. So when we think about all of these risk factors and diagnostic testing and kind of putting that whole picture together, really what we're concerned about with these patients is number one, falling, and kind of a subcategory of that is the injury that can occur secondary to that patient actually falling. So we want to really work on ways that we can prevent falling in our patients. We've talked about falling with patients multiple times. In this particular instance, while we may care for patients with osteoporosis in the acute care setting, we don't really see patients who are admitted to an acute care setting with for the reason of osteoporosis. Rather, perhaps they have some other type of acute illness, and they have a history of osteoporosis. So, in the acute care setting, it's useful to implement all of those standard fall risk precautions that we use for all of our other patients who are at risk for falling, like non-skin socks and bed alert, and putting items in reach, and ambulating safely with a gait belt and things like that. But really, when we're trying to prevent falls in these patients, we're looking in the community setting or in their homes. So we have to consider, how can we help patients to decrease their risk for falling in their homes. We think about things like, what might cause a patient to fall at home. Oftentimes, there might be clutter in a home. So, teaching about how to declutter traffic areas. Using proper footwear. I mean, we use non-skid socks to prevent falling in our patients in the hospital. So why not, talk about something like that, whether that be socks or, appropriate gripping shoes or something like that when they're walking around on areas of their home where, um, uh, where the floors might be slippery. Or something like that. If a patient does fall and experience a fracture, then they might end up in the hospital. That hospitalization could be more prolonged, and it increases their risk of death overall. Not saying that anybody dies directly related to osteoporosis, but it's more of like a chain of events that can occur and contribute to patients' decline in health overall. So, those safety precautions that we're teaching our patients about how to adapt their home so that they aren't going to be falling. Other things we can do to help promote strength and increasing of bone mineral density, and just overall health in our osteoporosis patients. Of course, weight loss is always something that we can encourage if that's a concern for our patients. If we have weak bones, the more weight that they have to bear and carry around, like body weight, perhaps the more likely they are to develop a fracture. We can work with patients on muscle strengthening so that we are also going to reduce the risk of falling there. Weight bearing exercises. Walking is a really wonderful weight bearing exercise. You can recommend, that your patient, walk routinely several times throughout the week. And then also, when it comes to activities, avoiding any type of exercise that's going to have a lot of jarring. So, in our young patients, like maybe we're targeting high school girls and how to increase bone mineral density, we might encourage running, as a good weight bearing activity to build strong bones. But when we're working with patients who maybe already have a diagnosis of osteoporosis, we don't really want them participating in those types of jarring exercises like running that could potentially, lead to some type of fracture or alteration in the bone. Bowling, if you want to call that an exercise, might be hazardous. Horseback riding, anything like that. Other exercises, that might promote core strength and balance are going to be good to just overall make the patient nice and strong, and build up that core strength so that their balance is better. Maybe yoga. I mean, sometimes that can kind of help, with balance issues and strengthening there. All of those modifiable risk factors that we mentioned a couple of slides ago, like smoking, excessive alcohol intake, excessive carbonated beverage intake, excessive caffeine intake, We can encourage and teach patients the importance of limiting those things or cutting those things out of their diet. We can encourage patients to add calcium and vitamin D into their diet. Lots of different types of foods have, an abundance of calcium. There are also a lot of fortified foods that contain calcium, like orange juice is oftentimes fortified with calcium. I think off the top of our heads, we often defer to dairy products like milk and cheese and yogurt and things like that are good sources of calcium. Not everybody can tolerate dairy products, whether it's like a lactose intolerance or maybe a lifestyle dietary choice like vegetarianism or something of that nature. But there are other things that have calcium, like green leafy vegetables and stuff like that. We can encourage incorporating that into the diet. Vitamin D intake can be increased through diet. Sometimes it's a little bit more challenging to get vitamin D through the diet. Some of those foods that naturally have vitamin D aren't very popular, things like liver and, you know, sardines and, fatty fish and stuff like that. But maybe if your patient likes that, that would be a good option. Again, many foods like grain cereals and stuff like that are fortified with vitamin D. But sunshine, getting out in the sunshine, just for even as little as 5 minutes a day, can be very beneficial in helping the patient synthesize vitamin D, which the body needs so that the bones can absorb the calcium. We can also talk about supplementation if we're not getting what we need through our dietary interventions, or maybe a patient can't really go outside for whatever reason. So maybe calcium and vitamin D supplementation um, would be a good option. Another type of medication or drug class that we use is something called bisphosphonates. So that kind of slows down the breakdown of bones, just as a normal process, how bones turn over and whatnot. We do know that there is a link between estrogen and bone mineral density. There's some people on both sides of the fence there with using estrogen to help promote increased bone mineral density and strength, because estrogens have side effects that can be um, undesirable in our postmenopausal women. Sometimes they can be very effective. But, for example, if someone has some type of cancer, perhaps, that is fed by the hormone estrogen, of course, we couldn't use it in that instance. But just the simple fact that there are other pharmacological interventions besides estrogen that can help increase bone mineral density, it's oftentimes not the first type of choice that we want to talk about there. Let's see. Patient teaching, include them in the plan. Talk to them about how, they can modify their home, how they can get maybe working with a physical therapist or something like that to incorporate strengthening exercises, or fitted for assistive devices like walkers or canes, so that they have more stability, especially if they have that curvature of the spine, so it can help prevent them from falling. We don't really do surgical management simply for osteoporosis, but what we're talking about here is more to do with, in the instance that somebody experiences a fracture, we might have to go in and do some kind of surgical intervention there. So a little bit about rheumatoid arthritis. This kind of goes back to our hypersensitivity concept that we talked about with the immune system. And with many of our autoimmune disorders, there is this component of a malfunction, basically, of our immune system. We know that normally when a body is exposed to an antigen, the body has antibodies that then kind of attach to that antigen, and it flags that invader, so that the immune system knows that it needs to take out that newly formed complex, that antigen antibody complex. The white blood cells can go in and devour it, and it gets cleared from the system. With some of these immune disorders like rheumatoid arthritis, there's a malfunction there in that antigen antibody complex doesn't get cleared completely from the system, so it's kind of left floating around, it'll find a home in a place. And in this instance, where it's going to find a home is in those cells within the joint spaces. So these immune complexes get lodged in there, and they start to cause inflammation in that synovium, that synovial membrane, which triggers the immune system, and new antibodies can be formed towards that antigen antibody complex, leading to uh, uh, the body kind of attacking itself. Rheumatoid arthritis is a chronic systemic autoimmune inflammatory disease, and it affects those freely moving joints, causing pain and swelling. That inflammation is what leads to the tissue damage, the joint destruction that occurs. So when we're thinking about rheumatoid arthritis, what we're really trying to target there is the inflammation that occurs because of that immune response. If we can control the the inflammation, then we can limit the destruction that occurs because of it. Now, we don't exactly know everything that leads to rheumatoid arthritis. Genetics can definitely play a part. You're more likely to develop rheumatoid arthritis if you have like a first degree relative that has rheumatoid arthritis. There are different environmental factors that have been linked to the development of RA, like smoking or different bacteria and viruses that can initiate the development of RA in genetically predisposed populations. So, I think we find this with many of our autoimmune diseases. We don't always know why they happen. We just can make some positive correlations between factors that are present and, subsequently the disease process that we are dealing with. We do know that women uh, between the ages of 30 and 50 are more likely to develop RA, and that risk even increases once they move on up into their 60s. So here you can see a comparison of a normal healthy joint to that of one that's affected with rheumatoid arthritis. That synovial membrane, it becomes thickened, which promotes the destruction of the joint. We can see narrowing of the joint spaces. We start to see an increase in synovial fluid, which impairs the movement, causes pain in the joint that's affected. The muscle is starting to waste away, and ultimately we're getting destruction of the bone. So all of this is taking place because there has been inflammation that has occurred within the joint. So again, if we can control the inflammation, then we can control or hopefully prevent the destruction of the joint. What we see in our patient relates to what is going on in the affected joint. We can see some early symptoms listed here on the left side. And typically with rheumatoid arthritis, we are seeing small joints of the fingers that are being affected, and it typically occurs in a symmetrical pattern, meaning it affects both sides as opposed to just one side. Oftentimes, the earliest symptoms that a patient may experience is really just generalized weakness and fatigue. Now, those are symptoms that can occur with lots of different things, so it can definitely be challenging for a provider to diagnose rheumatoid arthritis just because it is very vague general symptoms. As the disease progresses, we can see different types of symptoms like morning stiffness that's frequent, tends to last longer than 30 minutes. It just doesn't go away. We start to see an increase in pain. We could see excessive fluid accumulations within the joint space. We can see deformities of the joints that are affected. With rheumatoid arthritis, other organs can actually become affected, uh, such as the lungs, the heart, um, the skin, kidneys, blood vessels, salivary glands. All of these things can lead to problems such as like vasculitis or lung fibrosis or kidney disease. Now, they don't happen with everybody that has rheumatoid arthritis, but it is something that can occur. We call those extra articular effects, or things that happen outside of the joint. Um, Naturally, the way that rheumatoid arthritis happens is we have this period of remissions and exacerbations. So, patient may essentially experience flare ups of their symptoms. So, when we're treating our symptoms, hopefully we minimize those flare ups, but sometimes they can still happen, and they might need, some periodic extra treatment to help them get through those symptoms. Now, here we're looking at some of the deformities that can occur in the hands with rheumatoid arthritis. A swan neck deformity there on the bottom left, where we see hyperextension of that, that joint, that one that there, it's called the proximal interphalangeal joint. It looks kind of like a swan's neck if you look at that. The one on the top there is called a boutonniere's deformity, with an abnormal flexion of those proximal interphalangeal joints. And then on the right, we see something that we call ulnar deviation. And so those fingers are kind of have that lateral movement over towards the ulnar side of the wrist. If you think about a patient who maybe has one or multiple of these deformities, you might be able to imagine how this can impact their self care. So we think about ways in which we can promote self care with things like ADLs. Think about how difficult it might be to eat or drink or button your pants or perform self hygiene with toothbrushing and showering and things like that. Might be very useful to get like a occupational therapist involved in the care of somebody who has these kinds of deformities, so that the patient can be as independent as possible, because we want that. We want the patient to be as independent as possible, to promote self esteem and, self care and things like that. As nurses, we kind of have to meet the patient where they are, and provide assistance to help move the patient to the highest level of functioning that they can do independently. We don't want them to be completely dependent on people if they don't have to be for every activity. So teaching them some modifications can be very helpful. Um, these are called rheumatoid nodules. They're in the subcutaneous tissue over the joint. They're usually mobile, and I've heard varying responses about whether they're tender or whether they're not tender. Students have shared with me, family members have reported they're painful. I've cared for patients who've had these. Um, and they've reported that they're not painful. So I guess it just really depends on the person. So just, an example of something that you might see in the patient who has RA. We talked about some of these labs early on when we talked about the immune system, and there's really not one lab here that diagnoses rheumatoid arthritis. A provider is going to look at the whole picture and consider not only laboratory tests, but screening tools and history and things like that. A rheumatoid factor doesn't even diagnose rheumatoid arthritis. It is it measures the presence of IgG in the system for rheumatoid this rheumatoid factor. And even if it's elevated, it's just another piece of the puzzle that we can look at. We talked about how a CRP and an ESR can give us some information about inflammation. Again, not really diagnostic, but they can be useful in monitoring the course of the disease, or how well the patient's body is responding to treatment that we're doing. Your book also talks about a test called an anti-cyclic citrullonated peptide. This one actually is specific and sensitive, and if this is detected, this is a marker for aggressive and very erosive late stage disease. We do, again, we want to try to catch it early, so we want to identify those people who are at risk, perform our screenings, and start to implement appropriate medications so we can stop the progression of the inflammation. As you may have picked up on, as far as a nursing perspective goes, our priority concerns are, inflammation and pain. So, what are things that we can do to address that concern? Mobility and self-care issues. What are things we can do to address those concerns, and possibly a potential for decreased self-esteem and body image disturbances? So how can we kind of address those things? Inflammation is a tricky thing. I'll kind of cover that on the next slide. There are several types of medications that can control inflammation. But we want to make sure that we're giving the medication that works best for the patient and is advantageous for their problem. Other things that we can do for inflammation, good old ice can help with inflammation. I'm having cat drama in the background, excuse me. Pain, we've talked about lots of different things that we can do for pain in the past, whether that be medication or meditation or distraction, certain types of activity. We do want to encourage patients to be active, to be mobile. Heat can sometimes help if joints are feeling stiff. That might relax the muscles around the joints, thereby relieving pain. So we can go with a multimodal approach when it comes to pain control in these patients, with a combination of maybe pharmacological and non-pharmacological intervention. Mentioned on the last couple of slides, when we talked about some of those deformities that we see, there may be an impairment in a patient's ability to get up and move around. So we've talked about that. What can we do to promote mobility in a patient? And it's really just going to be specific to that patient. If we're concerned about mobility of the upper extremities, like how can we encourage self-care? Can we provide modifications to the environment? Can we provide modifications to frequently used tools like toothbrushes and silverware, and things of that nature? Do we have some weakness and strength issues? Should we consider maybe like a walker or something like that to help provide stability in a person who's trying to mobilize more independently? Is physical therapy going to be an appropriate intervention for a patient? Are they going to be able to help with things like strengthening and movement, kind of stuff kind of like that? So here we have some medications that we can kind of talk a little bit about. Number one, if we're thinking about pain, analgesics, that really just refers to medication that is for pain. They can help with some pain relief. It could be narcotics, it could be, simply acetaminophen, but really all they're doing is helping with pain relief. They don't have an impact on the alteration of the disease process in terms of inflammation, but they can be helpful in controlling pain. Anti-inflammatories such as NSAIDs can provide relief of discomfort and help to control pain, but the anti-inflammatory action that they exhibit is really not enough to alter the disease process. Glucocorticoids or corticosteroids, prednisone, in other words, can suppress inflammation and alter the disease process, that inflammation that we're worried about causing destruction, but they're not safe to give in high doses over long periods of time. They do cause some long lasting effects to the body. They can cause, gastric irritation. They can lead to osteoporosis. They can, cause issues with blood glucose control. They can shut down adrenal glands and cause problems. There. So it's definitely a good therapy. Maybe if a patient is having an acute exacerbation of their rheumatoid arthritis. But again, the high doses that are required to control the inflammation to prevent destruction just can cause too much damage. That risk benefit thing is kind of something that we need to weigh there. Sometimes we'll see patients who may be on long-term low-dose steroids as part of their treatment. But again, anyone that's taking steroids, we have to monitor them for those potential complications. Gastric irritation is something we also have to be concerned with in the patient taking NSAIDs. So if your patient starts telling you about gastric complaints and they're taking NSAIDs or they're taking steroids, or more importantly, both, then we need to take that into consideration and start to wonder, is there some sort of GI bleeding that might be occurring in this patient? Anymore, our first line treatment for patients who are diagnosed with rheumatoid arthritis are something that we call disease modifying anti-rheumatic drugs. Some of these medications include methotrexate, that's probably the most common one, but there are others like sulfasalazine and hydrochloroquine. These medications alter the immune system in ways that alter the inflammatory response. They do stop the inflammation, which stops um, the destruction of the joint. They do, however, also suppress the immune system. So when we have a patient who's taking these DMARDs, we have to be concerned about a risk for infection. Oh, that's another concept that we've talked about recently. So when your patient's on a DMARD and we know that they have an increased risk for infection, what are we going to be doing for that patient to reduce that risk? Good hand hygiene, staying away from people who are sick, reporting symptoms of illness, even subtle symptoms of illness, to their primary care provider. One thing that can be kind of difficult for these patients who are taking DMARDs, if they do develop an infection, oftentimes they have to stop their medication because it's working against their infection. And so because of that, we might end up with a flare-up of their rheumatoid arthritis, and that can be really difficult for patients who have good control of their RA, and they can maybe then recall what a flare-up of their RA is like, and there might be a little bit of anxiety surrounding that. It does usually take about 4 to 6 weeks for the anti-inflammatory effects of DMARDs to begin to take effect. So it's not something that they oftentimes see right away. So good education for your patient about that medication. It's also something that can cause birth defects if you're taking it. You recall back some of that, like what age is the patient that might develop rheumatoid arthritis? Well, it's actually relatively young. We can see it in patients as young as 30 years old, which are still really good childbearing years for our patients. So we really need to make sure that they understand if they are of childbearing age and they have been started on a DMARD like methotrexate, they need to be utilizing contraception because if they get pregnant while they're taking this medication, it could have serious consequences on the baby. It's very important that these patients are adhering to their treatment so that they have the best outcomes from that medication. Biologic response modifiers, these medications can slow or even stop the progression of the disease. They target specific parts of the inflammatory cascade. They aren't usually first line treatments. They tend to be more expensive. You have to go through oftentimes an insurance rigmarole to get them approved and covered by the insurance. Maybe you have to sometimes start with like a DMARD, and your provider has to show that it's not been effective in controlling your disease process or something like that. But they're more like IV infusions, sometimes subcutaneous injections. Examples are oftentimes we've heard these on the television commercials, things like Remicade or Humira or Enbrel. Those are all examples of biologic response modifiers. If a patient is going to be started on a biologic response modifier prior to that treatment, they have to get a TB test and a hepatitis test because these medications can alter the immune system in such a way. If a patient were to have a latent tuberculosis, or they were to have a hepatitis that they weren't aware of, then these infections could kind of run rampant and make the patient very, very ill. So they will have these lab tests prior to the initiation of that therapy. We've kind of talked about a lot of these things in the previous slides, but I'll summarize a little bit here. Pain and mobility, major areas of focus for these patients. So assessment of the patient's mobility and pain level, especially to the affected joints. We want to make sure that the patients understand their pharmacological treatment plan and the importance of adhering to it. Remember that we want to decrease the inflammation, and because this ultimately can slow the progression of the damage associated with RA. So some good teaching points there. Fatigue and self-care deficits can be an issue, so make sure we're taking those into consideration when we're talking to our patients. We can help guide our interventions towards mobility, towards energy management, maybe spacing out activities throughout the day or something like that for energy conservation. We do need to educate them on subtle signs and symptoms of infection because of the medications we're giving them can suppress the immune system. And so, they need to know when to report to the doctor symptoms that they're having. Vaccinations are important for these patients to help prevent infections like pneumonia or influenza or, things of that kind of nature. Let these patients do what they can. Don't just help. Wait to be asked for assistance. Oftentimes patients lose a lot of independence when they have, maybe some of the physical deformities associated with rheumatoid arthritis, or the fatigue, or, low energy levels, or what have you. So don't just be quick to step in and take over and do for them. Let them do as much as they can, and then when they ask you for assistance, then kind of step in at that moment. We kind of mentioned a little bit about adaptive devices. Talk about things like the weight of dishes or cups. Maybe a styrofoam cup isn't a good option for them because they have to use both hands to pick that cup up and exert pressure, and so it's going to put holes in it, right? Maybe a plastic cup is better for them. Maybe filling their cup half full instead of completely full. Maybe using plastic dishes instead of ceramic, or I don't know what dishes are made out of, but you know what I mean, like the ones that are breakable might be a better option for them. Talk to them about ways in which they can adapt holding like their toothbrush or their hairbrush, stuff like that. So osteoarthritis is the most common form of arthritis in this country. It is definitely a leading cause of disability, and it occurs because of changes within the joint structure. Now, those changes are different Then the changes that occur with rheumatoid arthritis, remember that's because of inflammation. With osteoarthritis, what we're seeing that's causing the joint changes is repetitive traumas, usually over a period of time. So all of these little micro traumas lead to stretching of the ligaments so that they lengthen, and eventually they just don't return to that normal state. And what we find is a loose or unstable joint. And I always think of the knee here. But other parts of the joint can wear down, such as the cartilage, which can lead to a joint that's not doesn't have a smooth surface to glide over. The patient can develop little osteophytes, kind of almost like little shards, that can lead to pain and discomfort within the joint, maybe decreasing the range of motion. And the synovium, that part of that's kind of lines the joint, can become thickened, maybe restricting movement and also contributing to pain. Now, with osteoarthritis, the joints that tend to be affected are our weight bearing joints. So, like our hips, our knees, our ankles, and they also tend to occur in a unilateral pattern simply because damage doesn't occur equally on side to side, those repetitive micro traumas. Now, just like with rheumatoid arthritis that primarily affects the small joints of the fingers, um, osteoarthritis can affect other joints. There's nothing that's saying that we can't have those repetitive micro traumas of like our wrist or our fingers. What I am saying here is where we usually see osteoarthritis is in those weight bearing joints. Certain types of occupations or athletes, certain types of athletes can be at higher risk for osteoarthritis. Think of those occupations or sports in which we have, um, you know, you, repeated pounding of a joint. Maybe I'm thinking like football or I don't know, rugby or um, running, like cross country, long distance running, or things like that, where we're really hitting hard on those joint spaces and leading to deterioration of the joint over time. Certain types of occupations, maybe like heavy machine operators or jackhammer operators, things like that, where we're really putting a lot of pressure and causing those injuries over time in those joints. Obesity is a huge risk factor for osteoarthritis, simply because those weight bearing joints have more that they have to carry around. Patients will experience pain. Oftentimes, the pain is worse with activity, and then when they rest, the pain gets better. They may also have some stiffness, but they tend to loosen up after a period of time, as the joint sort of gets lubricated after some periods of movement. They might have better range of motion, maybe even a little bit better pain control there. So that morning stiffness, unlike rheumatoid arthritis, tends to go away within about 30 minutes in the morning. Remember, rheumatoid arthritis, it kind of lasted for a longer period of time, but here with osteoarthritis, we see it kind of going away. We can see some swelling in the affected joint, or crepitus is a sound that we might hear when joint is kind of sliding over joint instead of having that cushioning of the cartilage between to make for a nice smooth glide. X-rays are really just going to show us joint space narrowing. You can look in your book. There's some, other diagnostic criteria there that a provider might use in the diagnosis of osteoarthritis. Had to think for a second what osteo I was talking about. So our priority problems for our patients with osteoarthritis are pain and decreased mobility. This is very similar in some ways to some of our priority concerns for patients who have rheumatoid arthritis. Some of the things that we do to intervene might look a little bit different, but many of our interventions might look the same. If a patient has, pain and stiffness and we want them to be active, then we might utilize heat to kind of loosen up that joint and make it more comfortable for them to participate in activity. After activity, they might experience some inflammation, so we might utilize ice for that. Analgesics can help with pain. Tylenol is actually the number one recommended medication for patients with osteoarthritis pain. That can be similar, right? We use that with with rheumatoid arthritis to help with pain and discomfort. A different thing here might be we don't use methotrexate, right? Because methotrexate is geared more towards suppressing that immune inflammatory response. So we're not going to use that here. So some similarities as well as some differences. Same thing with our interventions for mobility for these patients. We might have some instability in their gait, and so we might look at getting physical therapy involved for strengthening and joint mobility, as well as assistive device recommendations. Things of that nature. So again, just some things that might be similar and some things that might be very different. Another medication that's on this list that we saw as well on our rheumatoid arthritis list is the utilization of NSAIDs. So that can help with the inflammation. Now remember, with osteoarthritis, inflammation occurs after the injury and damage has happened, whereas with rheumatoid arthritis, it's the inflammation that leads to the damage that they experience. Corticosteroids can be used, prednisone, in other words, for patients with arthritis, osteoarthritis. It can help with inflammation. Usually, when we're giving a steroid to these patients, it's often a direct injection into that joint, which is a little bit different than maybe prednisone that's being prescribed for a patient who is having an exacerbation of rheumatoid arthritis. Weight loss activity can help by reducing the load that's being carried by the joint. Aerobic activity can also help with this. Always think of aerobic activity as running, but that's probably not always going to be the best option for these individuals, but swimming is a really good aerobic activity, and it also takes some pressure and stress off of that joint as they're performing that aerobic activity, strengthening other muscles, and things like that, but it's not putting the pressure on those joints like maybe running would. And of course, walking is always a wonderful activity for many things. I mean, we talked about walking as a weight bearing activity for osteoporosis, and here it's just a really good activity to get a little bit of aerobics, I guess, in. If you walk fast enough, keep the joints loosened up, keep the patient moving and healthy there. Surgery is going to be your last option. This is going to involve like a joint replacement. If that joint has completely deteriorated to the point where it's no longer functional, then a patient might have a joint replacement, such as a knee replacement or hip replacement, or whatever the case may be. Remember that we want to keep these patients safe, especially when they're ambulating. They might have an unsteady gait because of maybe pain in one of those weight-bearing joints, and so therefore they're at risk for falling. We know what to do for patients who are at risk for falling. We've talked about this a lot. We might use assistive devices like a walker or a cane. Again, we can get physical therapy involved to help us with that if we need to. Pain control, we've talked about different pharmacological interventions as well as non-pharmacological interventions to help with that, and encourage ongoing physical activity. Like I mentioned, low impact exercises are good for these patients. So we're going to move on to a little bit of injuries that might occur in our patients that are going to affect mobility, and we're going to come back to this word throughout the rest of this lecture, and that is neurovascular. So pay attention to that word. We're kind of going to learn a little bit about what that means in our assessment and in these injuries that our patients can experience. Our musculoskeletal system provides not only structure but also movement for the body. Right, we talked about how we need to have strong bones, we need to have strong muscles to kind of help these bones move. If we have weakness in one of those areas, we have a weak link in that chain, then we have a risk for injuries. Lots and lots and lots and lots and lots of injuries are reasons for visits to providers within the healthcare system, whether that is emergency care or outpatient clinics or whatever the case may be. But these injuries often yield very negative effects on the patient's mobility and sensation, and ultimately can impair the performance of their just normal everyday activities of living. So the first injury that we'll talk about is sprains/strains. Now, technically, these are different injuries. They're based upon the particular structure or tissue that is actually injured. So a sprain technically refers to an injury to the ligament, whereas a strain refers to the injury in a tendon or muscle. Ankle sprains would be the most frequently occurring orthopedic injury and are responsible for about 40% of all athletic injuries. Millions, in other words, of injuries every year. There are certain types of athletics that are more likely to see ankles sprains, things like basketball, ice skating, soccer, things like that, kind of like where we're bobbing and weaving or have to have really good ankle strength. I have runners in my life that seem to have a lot of sprains and strains.